Уважаеми колеги, бих искала първо да ви поздравя с 15-та годишнина на тази млада и винаги много енергична асоциация по клинична имунология и да ви поздравя и с провеждането на тази конференция, макар и в странните условия на предизвикателното време, в което се намираме. Темата на настоящата сесия са проблемите, които кръстосват пътищата на имунологията и онкологията, в частност на онкохематологичните заболявания. Със съжаление мога да кажа, че в времето на COVID тази тема малко остава в периферията, но ние не бива да я забравяме, защото тя е изключително важна, свързана с изключително сериозни здравни проблеми, научно-медицински проблеми, огромни крачки напред в развитието, в които път неизменно има имунологията, тъй като новите имунотерапии на онкологичните заболявания са на път да заместят и да пратят в историята традиционните химиотерапевтични и други подходи. За мен е изключително удоволствие да представя първия лектор в нашата сесия. It is a great pleasure for me now to welcome Alvaro from Barcelona, from the heart of Spain, and he will present us a very, very hot topic which binds immunology and oncohematology, and this is the new treatment technology of CAR T-cell treatments. And he works in a center in Barcelona, which is one of the leading centers in the application of this technology. So Alvaro, we are very glad to see you in a good shape and condition, and looking forward to your presentation.
Okay, so thank you very much for your kind words, and it is a shame not to be there with you, just with as we were in the past, just having very nice conversations about hematology. But I hope that in the future we will have the opportunity, and once this pandemic nightmare will disappear, that I'm sure that will disappear very, very soon. So thank you very much for inviting me to give this presentation about the CAR T and the treatment of oncohematological diseases. So CAR, as you know, very likely better than me, as you are immunologists. So CAR is the genetic modification of a T cell to give it a specificity against an antigen that we want to target, and to give it more strength, more potency, and more capacity of proliferation. And this is achieved by inserting, using a viral vector, inserting a genetic construct in the nucleus of the T cell, and this genetic construct will codify for a protein with an extracellular domain. This is just a small fragment of a monoclonal antibody, the single chain variable fragment of a monoclonal antibody, and an intracellular domain. This is the CD3 zeta chain. So the first signal, the recognition of the monoclonal antibody and the antigen, will be transmitted. This is the first signal. And a second part of this intracellular domain is key for understanding the activity, the efficacy of a CAR, is the co-stimulatory domain. So in just one protein, in one structure, the first signal of activation of the T cell and the second signal, the co-stimulatory signal, will be in place. So just contacting the monoclonal antibody with the antigen, the first and the second signal is in place. So this is very important because tumoral cells do not have, in general, in the vast majority of cases, a co-stimulatory domain. So for this is the reason of the name of chimeric antigen receptor. Part is a B cell, part is a T cell. The two most important targets for CAR treatment currently are CD19 and BCMA. So B cell lineage CD19 is expressed along the B-cell lineage, so all hematological malignancies originated from B-cell precursors, like acute lymphoblastic leukemia or B cells in intermediate stage of maturation of differentiation, like diffuse large B-cell lymphoma, CLL, mantle cell lymphoma, are excellent targets for CAR-19. These B cells lose the CD19 in the plasma cell level, but this plasma cell will express BCMA. So a CAR BCMA targeting BCMA will be an excellent CAR for treatment of multiple myeloma. So these CARs against CD19 and BCMA have been already tested in clinical trials in human. So probably this is the first, just that we were aware about the potency and efficacy of CARs and was in pediatric ALL. So children, young adolescents with in a very difficult situation with a refractory relapse ALL with an expected outcome of just weeks or a few months, achieve complete remission in 90% of the cases after receiving a CAR-19, and disease-free survival in 1 year was 50% due to a proportion of relapses. But the important point is that 50% of these patients with very poor outcome were disease-free 1 year after CAR administration. Unfortunately, results in adults are not so good. So in diffuse large B-cell lymphoma, it is now established that CAR-19 is able to rescue 30–35% of the patients in relapse refractory. So these results have been confirmed in 3 different clinical trials with 3 different CARs. Axicell using a CD28 co-stimulatory molecule, Tisacell with a 4-1BB, and Lisocell with a 4-1BB. Of note, these 3 different CARs use the same monoclonal antibody, FMC63. So you see how the durable complete remission is 37%, 30%, 52%. So quite similar, and considering that maybe in these clinical trials, the subtype of patients and the subtype even of the histological lymphoma was a bit different. But the important message is that CARs may rescue 1/3 of patients with expected very poor outcome in lymphoma. In multiple myeloma, there are 3 very important clinical trials with 3 different CARs, all of these 3 showing that patients in relapse or refractory multiple myeloma patients after 5–7 lines of treatment may achieve, again, a complete remission, a stringent complete remission in 33% of the cases, 36% of the cases, and with the CARtitude, a specific CAR is different to the rest of the CARs because this CAR identifies 2 different epitopes of the BCMA, and also the animal, the origin of the animal is not murine, is not human, is from llama. But the number of patients is still short to be sure that these results will be confirmed and in large series of patients, and also about toxicity. So we must know about the toxicity of this CAR. So it is a reality that CARs are very effective for rescuing patients with ALL, with non-Hodgkin lymphoma, and with multiple myeloma, and that there are commercially available CARs for ALL and for non-Hodgkin lymphoma. But the problem is that is the high cost per patient. So it's 1 CAR for ALL or for diffuse large B-cell lymphoma means 300,000 euros per patient. Another limitation is that not all countries may afford to use the CAR due to the price or due to regulatory aspects in that country. We may include the patients in a clinical trial, but very few centers are admitted for the clinical trial. The slots, the number of patients that we may include are also limited, and the clinical trial will not cover, in many cases, all indications, all subtypes, all ages for giving a response to this problem. So for this reason, we started 5 years ago an academic program for developing our own cars, our own car 19 and our own BCMA car. For doing that, this is the process that we perform. So first is we select T cells from the leukapheresis of the patients. We use an immunomagnetic method to select the T cells. We activate these T cells with an anti-CD3, anti-CD28. Once the T cells are activated, we incubate them with our own vector, with the genetic construct that will codify the anti-CD19 or anti-BCMA receptor. So, and the second step is to expand these transform T cells, with the genetic construct and expressing the receptor, is to expand these CARs, and we use a Clinimax Prodigy machine. So when we have enough quantity of CARs, we reinfuse to the patients after administering to the patient a lymphodepleted regimen. So this is our results in the first clinical trial that we have finalized, is in ALL, in acute lymphoblastic leukemia, children and adults. So results with our own CAR, we use a specific monoclonal antibody different to the FMC63. So for in the pediatric population, this is our results. Is at 1 year after CAR administration is 82% of disease-free survival. So we were very happy knowing that because most of these patients were in relapse after an allogeneic stem cell transplantation and refractory to the rescue treatment. For adult population, results are not so good as happens in other groups in the world using CAR-19 for adult ALL, but still, 1 year after CAR administration, disease-free survival was of 34%. So we rescued 1/3 of these patients, and we tried to improve these results. We use the CAR-19 also for CLL, for diffuse large B-cell lymphoma, mantle cell lymphoma. This is one of our first cases. This is a man relapsing after autologous stem cell transplantation. This is, you may see in the PET that there are many areas with active disease being refractory to the rescue after the autologous stem cell transplantation. And this is the results 2 months after our CAR. So this happened. This was administered, I think, 2.5 years ago, and the patient is still in complete remission and just visiting in our outpatient setting just every 6 months. This is a CLL case. This is one of our first cases. This was 3.5 years ago. So this was a woman that came to our hospital for allogeneic stem cell transplantation because she had refractory CLL, refractory to 4 lines of treatment. So we proposed her to administer CAR instead of an allogeneic stem cell transplantation because our experience in CLL with high tumor burden was not very good. So she evaluated pros and cons, and finally she decided to go to the CAR. So this is before CAR administration with, you may see in the axilla, very big lymph nodes. And this is after CAR administration, so lymph nodes disappeared. And here is in peripheral blood, she had a high amount of cells, of B cells, expressing CD19 and CD5, typical for CLL, and this mass of leukemic cells disappeared with the CAR administration. So now, 2.5 years after CAR administration, she is still in complete remission, minimal residual disease, negative. So this is for CAR-19, and we have started a BCMA program, so a program to treat multiple myeloma patients. So what we have done is first is the genetic sequence of the single chain variable fragment of this monoclonal antibody. We have linked to a 4-1BB co-stimulatory molecule and to the CD3 zeta. So we have introduced this genetic construct in lentiviral particles, third generation lentiviral particle, and we incubated this lentiviral particle with a T cell. So first is we demonstrated the efficacy against cell lines expressing BCMA and also the specificity of this CAR BCMA. So these T cells expressing the BCMA receptor, the anti-BCMA receptor, were very effective eliminating cell lines expressing BCMA. In contrast, this cell line, these malignant cells survive after incubation with T cells without our genetic construct. And you may see here the specificity of the CAR, incubating the CAR BCMA with a cell line not expressing BCMA, so BCMA negative cell line, cells survive in the presence of our CAR. So we wanted to go ahead and with in vivo experiments. So we administered to the mice, to a group of mice, 1 million of tumoral cells. So 35 days we sacrificed the mice due to the progression of the tumor. In contrast, those mice receiving 5 million of CAR BCMA, murine CAR BCMA, the tumor was didn't develop, so the mice 35 days after administration were in a healthy situation. We know that the murine component of the CAR may trigger immune rejection of the CAR. This is one of the reasons of short persistence of the CAR in peripheral blood. For that reason, we modified our CAR BCMA, and we humanized the CAR, the single chain variable fragment, and we try to demonstrate the same efficacy of our CAR BCMA humanized in relation to, as compared to the murine CAR BCMA. So you may see here that the results eliminating the tumor were very similar to the murine CAR BCMA. So we finally selected the humanized CAR BCMA for our clinical trial. The name is Ari because it was the name of a patient that unfortunately died after an allogeneic stem cell transplantation, and she and her mother were very active in obtaining resources for our CAR program. So our CARs are named Ari1, Ari2 in her honor. So once we had this CAR BCMA for translating to the clinical trial, first is to prepare enough quantity of lentiviral particles for incubating with the T cells, for transfecting T cells. So we used an hex cell to package the genetic construct with the different plasmids to create the lentiviral particle. And this was performed in a GMP facility, a bit expensive and quite sophisticated. In a typical procedure of production, lentiviral takes 14 days, and in 14 days we obtain enough quantities for 16 patients. So for the bioreactor, we use a Prodigy machine. It's quite simple for units with enough experience in cell therapy. Is closed. It is considered itself a GMP facility, and it's quite automatic. So we introduce 100. So we start with 100 million T cells, and 10 days after, the number of T cells are 30 times higher. So it's multiplied by 30. This is the cards. Is from day 7, we may identify a good quantity of cars that that increases, but not at the same proportion of T cells. So the proportion of T cells is higher with the time. The proportion of CAR T cells is lower with the time. So we stop the procedure currently 8 days after CAR expansion. One question is what subtypes of CARs do you obtain after this expansion? It is an important matter for persistence. So we have studied this aspect, and we, as an average, we have 44% of the CARs in the product are associated with long persistence, naive cells, stem cell memory cells, or central memory cells. Another question that we were wondering is would we have enough CARs for clinical for the clinical use? So you may see that the number of CARs that we obtain after an expansion is very high. Is if we make an estimation within an adult or in children, you may see that we could administer. We would be able to administer to a concrete patient 20 million of CARs per kilogram, or in case of a children, in case of a pediatric patient, close to 70 million CARs per kilogram, when we need a much lower quantity of CARs in our program. Is 1 million, 1 times 10 to the 6 CARs per kilogram in case of ALL, in acute lymphoblastic leukemia, or 5 times 10 to the 6 CARs per kilogram for non-Hodgkin lymphoma. So we obtain much higher quantity than we actually need for a patient. So once we had everything in place, we have started the clinical trial with the CAR-BCMA. Regulatory aspects are also, it takes a long time with documentation. So we have contacted several times with our Spanish Agency of Medicine before starting the clinical trial, either the CAR-19 clinical trial or the CAR-BCMA clinical trial. They have guided us and explain us the weak points or points that we need to review. So it takes like 1 year, at least 1 year, to receive the approval of the Spanish Agency of Medicine. But finally, we have received the approval for the also for the CAR-BCMA multiple myeloma. We have modified a bit our strategy. So instead of with the CAR-19, our center was the producer of the lentiviral, the producer of the CAR, and all patients have been treated in our hospital. In contrast, with the CAR-BCMA, we try to decentralize the CAR production and CAR administration. So lentiviral production, which is difficult, expensive, and needs a very specific facility. So the lentiviral production will be in our hospital, as it is with the CAR-19. So this is centralized, the lentiviral production. Lentivirus is distributed in 2 centers, our own center and to another hospital in Spain, to produce the CAR. So to do the prodigy part of the procedure. And once the CARs are produced here in the Hospital Clínico Barcelona or the other hospital in Spain, these CARs are distributed to 5 different hospitals in Spain for administration of the CAR. So first, the Spanish Agency of Medicine asked for the demonstration of the similarity of the product independently of the center, either at the hospital clinic or at the University of Navarra, the other center. So what we did is to do three cases in healthy donors. So one leukapheresis of a healthy donor was divided in 2 parts. One part was processed with the Prodigy machine at the hospital clinic. The second part of the same leukapheresis was processed at the at the University of Navarra. So you may see how the CAR production were very similar in both centers using the same donor, and here the same with the case 2. So it's quite consistent. We have performed now like 100 procedures with the Prodigy machine, and it's quite consistent in terms of reproducibility and the number of CARs that we obtain after the procedure. So this is the protocol with the CAR BCMA in multiple myeloma. This is the standard lymphodepletive regimen. We use the same treatment with the CAR-19. Is quite standard, internationally considered standard. So the difference with respect to other clinical trials is that we fractionate the dose. In this case, we use 3 times 10 to the 6 per kilogram, but fractionated. First, we administer 10% of the total dose. We wait for 1-2 days. If the patient does not develop CRA, cytokine release syndrome, we administer 30% of the dose. If we wait 1-2 days, if the patient does not develop CRS, we administer the remaining dose to adequate the dose to that patient. So to know whether the patient is developing a CRS and stop the dose. In this clinical trial, we plan to administer a second dose 3 months after the first one to consolidate the treatment, to refresh the CAR T cells that we administer to the patient. So these are the 2 most important differences. Indeed, this is the CAR itself is different. It's a CAR BCMA different in the monoclonal antibody, but the strategy is also different with respect to the centers participating, that the production is in 2 centers, and also in the fractionating the dose and administering a second dose. So this is the clinical trial has already started. I can't show results itself of the clinical trial because we need to finalize the clinical trial to show the results. But let me show you one. The first case was a compassionate use. So it was just before the clinical trial was started with the humanized CAR BCMA. So in a patient with a multiple myeloma refractory to 5 lines of treatment, refractory to an autologous stem cell transplantation after 2 clinical trials. So the patient, this is the activity in the serum of the multiple myeloma cell, the plasma cell infiltrating the bone marrow. So we administered the CAR, and just 1 month after administering the CAR, disappeared the presence of the M spike, M component in the serum, and the bone marrow was normal. And this patient, 3 months, so slowly, the malignant component was disappearing. 3 months after CAR administration is in stringent complete remission. This was 5 months ago, so we must wait until we may say that the complete remission is maintained. So in this clinical trial, we have already included 20 patients, so the rhythm of inclusion is very high, so there are many patients with multiple myeloma with this need. with this medical need of a CAR. So 25, the target is 30 patients, but we have already included 20. The CAR has been produced in both centers, Hospital Clinic and Hospital of Navarra. We have administered the CAR in the 5 centers that are in the clinical trial. So, and the expected end of inclusion is in December. So we will finalize sooner than we expected this clinical trial of CAR BCMA. So what is the next step in our hospital is to obtain which is called the hospital exemption. So for CAR-19, the Spanish Agency of Medicine is just on the verge, just accepting us to use our CAR-19 as a, let's say, commercial product in Spain. So the CAR BCMA, after finalizing the clinical trial, will go to the Spanish Agency of Medicine. If they consider that our CAR is effective and and toxicity is low, may consider also this hospital exemption, the exceptional use of our CAR without going to the EMA. So that's all. So thank you very much for your attention. This is the team. There are other people involved, but it's very clear that the CAR means multidisciplinarity. This is extremely important group. Manel Juan from the immunology department. Now it works like the same team as we are. We have a daily interaction with Dr. Manel Juan. The research group, very important to this multidisciplinarity involves basic researchers. This is key because we are physicians, so we can't understand well all the procedures and how to do it, how to do these procedures. This is the clinical, and so many other people from pediatric, from intensive care unit. And this is Ari, the person that with her mother achieved enough resources for starting the clinical trial. So thank you very much, and I would be delighted to answer the questions from the ground. Thank you.
Thank you. Thank you, Alvaro, for your very nice talk and intriguing topic. So if there are any questions from the audience, we have a small audience here that is able to ask questions. Are there any questions? No. May I ask you something? Since this is, well, the new revolution in oncohematology and with promising results for oncology in general, do you think that countries like Bulgaria with quite more limited resources might be able to develop the technology in the next coming years? And what would be your advice in this regard?
So I think this is a key question because I think there is an alternative to the commercial cards. And I think that in Europe, this is a movement in favor of doing what we call point of care production of the CAR. So we may either buy the genetic construct there are already companies that may sell this genetic construct or may provide with the genetic construct. And so, and in the different hospitals, in Bulgarian or in other countries, the CAR may be produced with either the Prodigy machine or I think that there are a couple of companies developing very similar system. So what I would add, what I would do maybe in your country, if we may advise, is just to establish an agreement with a provider of the genetic construct and to run a clinical trial with resources from the government and to do in a certain number of patients, 30, 50, 100 of patients, using these bioreactors, not very difficult to use them, and with the genetic construct provided by either an academic institution or through a company. So I think that this is feasible and is what I would do. Maybe in a second step or in parallel, maybe different groups in Bulgaria may start the production of their own genetic construct. But I would use first a well-known genetic construct that has demonstrated the efficacy and toxicity. But it will depend of the immunology society whether there are or not groups already preparing these genetic constructs.
Thank you. So we are coming to collaboration and networking at the end. Thank you very much, Alvaro. Take care of yourself and stay healthy, and we wish you all the best and hope to see you soon in live sessions as well. Bye-bye.
Thank you very much. The same for you. Thank you very much. Bye-bye.
Bye-bye. Thank you.